Good morning, friends. So now we are moving to the next session of retinal imaging. Is Dr. Ramandeep is on here? So myself, Dr. Vishali, we are conducting this session of retinal imaging, and at the very outset, I invite Dr. Singh, and we'll be discussing on normal versus abnormal on OCT.
Sir, and thanks to Dr. Suresh Gupta and the team at GMCH for this kind invite to be present here. So I'll be talking on one of the imaging modalities that we use most commonly in ophthalmology and in retina especially, that is optical coherence tomography. It is a non-invasive imaging technique that generates high resolution in vivo cross-sectional images with a very high resolution, as you can see when compared to the other imaging modalities that we have, MRI and CT scan, which have more depth but the resolution is very less. And here we can see almost even up to 1 micrometer difference between 2 points. And with the use of the near infrared light sources and scanning laser ophthalmoscopy based systems, even more deeper penetration and axial resolution are possible. This is a short timeline of the OCT that we have had. The 1990s was the time when we first got to see cross-sectional images of the retina in vivo on OCT. And now after that we have come 3 generations further from time domain, spectral domain, swept source, and now OCT angiography also. So time domain, just a basic concept. It used a reference arm and the human eye and measured kind of like the ultrasound the time taken for the waves to come back, and then measured the depth of the tissues and generated the cross section from that. With the Fourier domain, that is the next technology that includes both the spectral domain as well as the swept source OCT. They use the interference pattern of the waves and to see what kind of tissue that the light waves are striking and coming back. Thus they get a lot more data. So then OCT angiography, as will be talked in the next talk, is a derivative of the information that we were already getting from the Fourier domain OCTs. So just a comparison of the time domain, spectral domain and the swept source. As you can see here, a very low resolution image that we used to get with the time domain, and with the spectral and the swept source you actually get to see the exact human anatomy as we used to study in the anatomy books. And as these generations of OCT have gone, more and more scans are passed per second, hence the speed has increased, and as more and more scans are averaged together, the quality of the OCT increases. So in lesser time we get better quality OCTs now with the swept source and the spectral domain OCT. So this is a very important slide and a paper that everybody should go through before reading a OCT. That is the normal lexicon for reading a OCT of each of the retinal layers. So we read 10 layers of the retina on human anatomy. There are 18 that are visible on OCT. So each of these is very important, but I would like to stress on these 4 outer hyper-reflective layers that you see that are marked here. That is the external limiting membrane, the ellipsoid zone, the interdigitation zone, and the RPE Brooks complex. So these 4 are the most important determinants of vision, and thus when we are reading a OCT scan, seeing these layers will give us an explanation as to why the patient is seeing less or why the patient is seeing more. So these 4 layers are very important, and if you see the anatomical correlate of these with the neuron, with the retinal structure, they all correspond to parts of the photoreceptor only. And this is just a depiction of the blood vessels, and this will be discussed further in the next talk once we talk of OCT angiography. So coming on to abnormal OCTs, this is something very striking. We are very used to seeing this very nice foveal dip, and that we kind of concentrate most on. When you get this type of OCT in a young child, what do you think? So you see this scan is passing right where the fovea should have been. Even clinically you can't see much of a dip, and the scan is going absolutely straight. So this is what we call as fovea plana, or a foveal aplasia, hypoplasia. And the next pathology, as you can see, again concentrating on the dip, you see a very nice dip here, but you see this vitreous that is firmly adherent to the dip. So this is something we call as vitreomacular adhesion, and here that adhesion has kind of pulled the retina a bit and distorted its contour, so that's vitreomacular traction. And when this progresses further, this is what we get, that is a macular hole. When it pulls off the retinal tissue along with, here there is still some vitreous attached to the edge of the hole, and here it has kind of detached from the edge of the hole. So again, a very important paper, the International Vitreomacular Traction Study Group classification, which gives you the exact nomenclature for these terms and and why do we divide them the way we divide them according to the prognosis that the patient is going to have. Again, an important paper that all of you should read. This is a very common case that we see, that is diabetic macular edema, and we mostly see just the edema, but there are a lot of things in this that are used as OCT biomarkers to tell us that whether the patient is going to gain vision or not. You can see two types of hyper-reflective dots that you see here, ones with a lot of back shadowing here and ones with not so much of back shadowing. So both of these are very different. These are the hard exudates that we see, and this is something called as the hyper-reflective foci, which are suggestive of inflammation in the eye and thus give us an idea that the eye may be better responding to anti-inflammatory drugs rather than anti-VEGF drugs. And now again you can see here the inner layers of the retina here are kind of mashed up. Again, that is something called as drill, disorganization of retinal inner layers, which tells us because there the blood supply is coming into the retina, so that is disrupted over there, hence these layers are gone. And of course you see the intraretinal as well as the subretinal fluid that we mostly treat in these patients. Another patient of diabetic macular edema, I just want to show, we are very used to getting those printouts from the machine that we look at, and if you look at this printout you would say okay, the patient is doing fine, not much of edema. But if you were to look at all these scans, you would get a very different picture and you would see that there is a lot of edema over there. So it's important to go to the machine and actually look at all these scans before making your impression of the patient. Again, a common case, that is a branch vein occlusion. Here it is a superiotemporal macular branch vein occlusion. OCT gives you very nice details of the cystic spaces inside the retina, and you would want to treat this with anti-VEGF, and OCT gives you a very nice follow-up of the patient, and you can actually show to the patient and tell them that yes, the edema is going, and then coming back you inject again, it goes, and the cycle goes on. But it gives you a lot of information to follow up and treat these patients. So again, a very interesting scan. As you can see, this part of the retina looks like it's shaved off. So this patient presented with a paracentral scotoma, no other complete 6/9 vision, but was very disturbing scotoma. The fundus to looked absolutely normal, but the OCT shows you the pathology that the nasal side inner layers are completely gone. So the OCT angio, which will be the next talk, kind of shows you what the cause is, that there is a serous-retinal artery occlusion that is causing a ganglion cell loss over here, which is the cause for this scotoma over there. This is central serous chorioretinopathy, a subretinal fluid pocket fluid pocket, along with some PEDs and a very thick choroid that you see, the large choroidal vessels kind of compressing on the choriocapillaris, which is part of the pachychoroid spectrum as we talk. So this is central serous chorioretinopathy. This patient you would want to observe, take care of the risk factors, and then maybe decide on an FFA and treating him if required. A very similar patient who has come to you again with this pocket of fluid, but here you see this what we classically call as the double layer sign, splitting of the RPE and the Brooks membrane. And when you see that hyper-reflective layers between that, so that is very much suggestive of a neovascular membrane, and you can confirm that with the OCT angio, and then this patient would be treated with anti-VEGF drug. Age-related macular degeneration again helps us a lot in determining the level of the fluid, and in such a case when you see, we talked about the outer retinal layers, they are completely destroyed in the central part of the retina. There are no outer retinal layers. So this patient will respond to anti-VEGF, but the visual acuity will not increase that much. So there is not much fun in treating this macula. Another variant of age-related macular degeneration in which you get massive bleeds subretinally, that is the polypoidal choroidal vasculopathy. Again, the OCT tells you very nicely the level of the bleed. This is the subretinal component and this is the sub-RPE component, which is a hemorrhagic PED. And again, on follow-up, you can very nicely see the resolution and also show to the patient, gains their confidence a lot, that yes, you are responding to the treatment that you have instituted in this patient. So another case of subretinal bleed in a young girl post-trauma, you would think that yes, the bleed is very small, some subhyaloid bleed over here, the patient should do well. But you do an OCT and you see this large choroidal rupture over here with that blood erupting out from the choroidal rupture. So it gives you a lot of information that even after this, blood is going to go away. But because of that choroidal rupture, the visual acuity gain is going to be modest. And just the last three cases, again you see the cystic spaces and we would like to think this is cystoid macular edema. But when you see a bilateral symmetrical picture, these elongated spaces and extending beyond the foveal region, this is not cystoid macular edema, this is retinoschisis. This is a case of RS1 proven X-linked retinoschisis. The diagnosis here is not in doubt. This is rod cone dystrophy or retinitis pigmentosa. This patient has 6/18 vision. So OCT gives you very important information that you see these photoreceptors are kind of spared at the center and completely lost in the periphery. So this information is now going to be very important once we are going into the era of gene therapy, when the OCTs with preserved layers would be the ideal candidates for gene therapy. And this last case, which is kind of my favorite, that 6-year-old girl who presented to us had been following up with our pediatric ophthalmology colleagues with absolutely no clue why she had nystagmus, why she had such a low vision. Fundus had been repeatedly examined and you see fundus look kind of absolutely normal. The OCT gives you a very clear diagnosis. You see this focal defect of photoreceptors right at the foveal center. So this is a clear-cut case of achromatopsia, and this came out to be positive for CNGB3 gene mutation. So OCT technology is rapidly evolving. I have just tried to show you some scenarios. This is just the tip of the iceberg of what we can see with the OCT. And OCT biomarkers are guiding us in treatment, and they are going to be involved even more in management of these patients. We need to take time to analyze each scan. We are gathering a lot of information, but we are using a very little bit of it. So we need to take time to analyze each scan for the finer details and go through all the scans before making a decision for the patient. Thank you, and a special acknowledgement to our retina lab team at AEC who have taken all these images and beautiful OCTs that I showed. Thank you.
Thank you, Dr. Simar.